Thank you so much for inviting me to talk. I'm going to shorten my talk a little bit just in the interest of time to really get into the meat of it. You know, there's just my disclaimer, of course, all these treatments that we're talking about today are, at least in the US, you know, we like to use FDA-approved treatments, but really we only have 2 FDA-approved treatments for autism. They're both antipsychotics. They don't even really treat the core symptoms. So everything we talk about is off-label use, so it's just really important to consult with a medical doctor or have a medical doctor that's very familiar with these treatments guide you. So there's a whole history I'm going to go through quick of really how we found out about about immune disease in autism. Some of the first evidence was that we found there's family history of autoimmune disease in families. And really the seminal paper was this one by Carlos Pardo and Andy Zimmerman from the Kennedy Krieger Institute at Johns Hopkins, who actually looked at the post-mortem brain of individuals with autism and compared them to those with without autism. And it's pretty obvious what they found in the cerebellum, which is this part in the back of your brain, is that if you look at the normal cerebellum here post-mortem, it looks all nice and tidy. And you can see this is what it looked like in an individual with autism. And when they stayed for inflammatory markers, all these little black dots are inflammatory markers. So they found that there seemed to be brain inflammation. One of the things they did was measure these cytokines, which we just heard a little bit about. And they found that there were certain cytokines, IL-6, TGF-beta1, and MCP1, that were elevated in this brain tissue of the kids with autism. And then what they did is they verified this. They actually took a separate group of, kiddos, and they did lumbar punctures to measure the cytokines in the cerebral spinal fluid. And what they found is there was a whole host of elevated cytokines, including the ones that they had found in the brain on the autopsies. Others have found that there's differences in human leukocyte antigen, HLA haplotypes, which predispose us for autoimmune disease related to autism. And we published a paper a while back showing that some of these kids, depending if you have the HLA CW7, you actually have a certain phenotype of autism. A lot of work has been done by Dr. Janucci, who's in New Jersey. She's really one of the wonderful immunologists we have in the US. And she looks at the IL-1 to IL-10 ratio and thinks that we can subtype kiddos with autism based on this. And in this paper, we actually connected that ratio with dysfunction of the mitochondria, which we heard about a little bit in the previous lecture. But one of the things we do see that is kind of a subset of the immune dysfunction is that we see antibodies that are directed to the brain in kiddos with autism. And really, there's lots of studies that have shown this, and they've shown that there's a whole host of different antibodies that have been found to be directed to the brain if you look at the kids with autism. Of course, the question is which one of these, is really doing something bad and which one of these just seems to be a bystander. And so we'll talk about that in a little bit. One of the big areas that we've heard about just briefly before, but really I think is something that's very important, this is finding that about probably 20% of individuals or mothers that have children with autism have these maternal fetal brain antibodies. And so there's an interesting study from the Mind Institute led by Judy Vanderwater and Paul Ashwood, where they actually looked at mothers of kiddos with autism, and they found that in the mother's blood, they had these certain bands when they looked for antibodies, these 37 and the 73 bands. And they later were able to actually find out that these were specific antibodies against fetal brain. And they estimate that probably about 20%, this may account for about 20% of autism, that there might be these fetal brain antibodies where the brain is actually affected because of this immune reaction actually prenatally. But we see kids with autism, after they've been born and they've been diagnosed with autism. And one of the things that we can look for is whether they actually have some type of not only immune activation, but whether there's some type of antibodies that are actually directed towards the brain that may be causing inflammation in the brain or brain dysfunction. And in neurology, we put this under something called autoimmune encephalopathy. That is that you have an autoimmune type of process that's causing the brain not to work. So we published this study a couple years ago. This published in Translational Psychiatry. With our experience when I was at Arkansas Children's Hospital for about 6 years. Kiddos that came in with autism, we have a whole workup for them. We usually look for metabolic causes, seizure causes, genetic causes. And if we don't find those, sometimes we go on to look for autoimmune encephalopathy. And this is our experience with 82 patients that we evaluated with autoimmune encephalopathy. And usually we do a whole host of immune markers. We usually do the Mayo panel, which looks for markers for antibodies against the brain there, and it's kind of a subset. Not all the panels are comprehensive. The Mayo panel specifically looks for the NMDA receptor encephalopathy. We didn't find any of those positive, even though there has been reports of that in the past. But out of our workup, the other thing that we do is something called the Cunningham panel, and the Cunningham panel looks for a number, 4 different anti-brain antibodies. In addition to that, it actually measures something called the CAM kinase 2. And the CAM kinase 2, I really like the Cunningham panel because the CAM kinase 2 elevation actually tells us and verifies that the antibodies that are seen on the panel may actually be disrupting the way that the neurons work. And that is that the way that the assay works is they don't only measure these antibodies, because sometimes antibodies can actually be binding onto brain elements or other elements, and sometimes they don't. You don't know what they're actually doing physiologically. So in the Cunningham panel, they actually take the blood sample and they put it on a neurocell line to see if it actually activates one of these major enzymes in the cell that we believe is the final common pathway to causing a lot of dysfunction called CAM kinase. So out of the 82 patients that we evaluated, we found about 60 of them seem to have some indication to go on for immunomodulatory therapy. And what we use for the first therapy is IVIG. And here we have a list of the different indications that we found. Out of the 49 patients that we recommended IVIG on, 47 of them actually agreed to it, and we ordered it. And this is, and we don't do self-pay for the most part. We go through insurance, and you can see here our experience that about 77% we were able to get insurance coverage, usually taking somewhere between 6 to 9 months to actually get the insurance to pay for it. Out of the 36 patients that were prescribed IVIG, 31 of them received it under our care, 5 went to an outside team, and that's what I'll talk about today. We look at actually how many, what dose we used. Of course, we've been talking a little bit about the dose of IVIG. We always start at 2 grams per kilogram given over 2 days monthly. And then I think it's really, really important that as you treat these children, you follow them along to actually customize what the dosing is and the interval. And so you see, this is what we started out with, and we did a little bit of a variation depending on the patient, but you can see where we ended up. And so most of the individuals continued with that regimen of 1 gram per kilogram per day for 2 days monthly, but it was only 37% from the 74 that we started out with. And we really had to customize it specifically to the patient to get the optimal response with the without having major adverse effects. And nobody had major adverse effects, but there's minor adverse effects that make it uncomfortable sometimes. So you really have to, look at that. So what were our outcomes? So our outcomes, we asked, we went through the clinical notes to see what the parents mentioned to us kind of spontaneously of what they saw improve in their children with IVIG. And most found that it was communication and language improved. Second was aberrant behavior and repetitive behaviors. If we look at the number of symptoms improved, for the most part, of these symptoms, at least 2 of them improved in 35% of the patients, and then 3 and 13%, and so on. So there was only, if you look at this, there was only about 29% that got a limited response with no or maybe 1 symptom improvement. Only 10% had no symptom improvements. What we also do, what I do in my clinic is every time I see a patient, we have the parents fill out some standardized, validated questionnaires that we use in autism research in order to follow along symptoms. And 2 of the most important ones are something called the SRS, or the Social Responsiveness Scale, which measures specifically autism symptoms, and then the ABC, or the Aberrant Behavior Checklist, which looks at disruptive behaviors. And you can see here, just in general, overall, that there were significant improvements with IVIG in cognition, in mannerisms or repetitive behaviors for autism-specific symptoms, and in the total score. More so, we got improvements in aberrant behaviors. So there was improvements in irritability, social withdrawal, also known as lethargy, hyperactivity, speech, and the total score of aberrant behavior went down. We can look at it this way. So this is a graph of the ABC score on the bottom here and the SRS score over here to see how many kids made improvements. And you can see that there's 1, 2, 3, 4, 5, 6, 7 of them that improved in both areas. There's 3 that really only improved in social responsiveness, that is more specific autism symptoms, and 4 that improved in the disruptive behavior and not autism symptoms, and 4 that really made kind of limited improvements. So you know, one of the things I want to mention again is this this measurement that we use in the Cunningham panel called the CAM kinase 2, and we find this is very useful. And this was really developed in the pandas world. And what Dr. Cunningham, one of her major contributions was that she found, using animal models and then also in human studies, that when these antibodies bind onto the neurons, what they tend to do is activate CAM kinase 2. And CAM kinase 2 is a major regulatory enzyme, and it does a number of things. Here, this slide mostly concentrating on what we see in pandas. It upregulates the production of dopamine, and that's when you can get abnormal movements and disruptive behaviors. It also, which is not in this slide, also increases the trafficking of the NMDA receptors. So it actually increases glutamate transmission, which we think is responsible for some of the more repetitive behaviors and the cognitive effects. So one of the things that we did is that we had all these measurements that we did at baseline to look for, you know, reasons or indications to treat. And so what we were able to do is go back and then ask, well, are any of these things predictive of kiddos, and what can predict if they're going to respond to IVIG? And what we found is that of the four antibodies, brain antibodies that the Cunningham panel measures, D1, D2L, anti-ganglioside GM1, which really we didn't see because these were not pandas patients, these are autism patients, we really didn't see elevations in that. And anti-tubulin, we found that those that had high D2L antibodies or tubulin antibodies were found to be more likely to respond to the IVIG. So we're looking for a biomarker. And then And then the other thing we were able to do is we were able to correlate the titers of these antibodies with the change in the ABC score, or the aberrant behavior checklist. And so here we can see that the higher the D2L antibody, the bigger the change in the aberrant behavior checklist. That is, the more improvement in behavior with IVIG. And the higher the antitubulin, also the greater the improvement in behavior. And then there's another measurement that's been used in the past, which was the D2L to D1 dopamine receptor ratio. And we found that that actually was the highest correlated, that ratio of antibody titers had the highest correlation of improvements with IVIG. So this is looking for a biomarker that actually tells us which kiddos are going to respond to IVIG, because one thing we know is that autism is very heterogeneous, and so sometimes you really, need a marker to tell you what treatment is going to be helpful. We also divided kids up into those who were responders and non-responders to look at what kind of their profile is, over time. And what we found is that if you look at the responders, which is here on the left, which I think is very telling, because a lot of people want to know how fast is my kid going to respond to IVIG? And these are the changes in the aberrant behavior checklist over time. And we can see that there's some kids in one treatment, they really had this drop in the ABC very quickly. But then there's other kids where you can see the change is very slow, over, this is 1 year time here. So some of them are very slow, and it happens over a year. Sometimes we have little upswings and downswings. Another one that had dramatic effect. So it's not a one-size-fits-all type of things. Usually with one treatment, you really don't know. And so it's important to realize that as you're treating kiddos. There's a couple of cases that we reported in this paper, which I think are really telling. This is a great case. This is a kid, because one thing we do see is that there's mitochondrial dysfunction many times, or other types of metabolic abnormalities that come along with autoimmune encephalopathy. And it's really important, if anything, I should say, is that it's really important that you have to find all the things that are going wrong, and treat them. Because if you don't, then you're not going to get optimal outcomes. And we have many kids that we've done IVIG on who, because they had an underlying mitochondrial disorder, they didn't respond well. Or I've had parents that would, take the kids off of the mitochondrial support because they said, oh, we're doing IVIG now, we don't need that. And the kids would fall back. So it's a really important thing to understand these things come together. This kid, though, was interesting because we identified him early on at 6 years old as having a mitochondrial disorder, and we actually treated him. And you can see we're following along the SRS, the social responsiveness scale, and the aberrant behavior checklist. And actually, with mitochondrial treatment, his behavior became much better. But then there was I should say, an immune trigger that happened here. And you can see what happened to his behavior. It spiked up. And that's when we looked for something more, and we started IVIG. And as interested with IVIG, not only did his behavior get better, but his social responsiveness scale, his autism symptoms got dramatically better. And actually, after I'd say about 3 years of IVIG, he was in a normal school, functioning normally. The interesting update to that story is that we stopped IVIG for several years, and he kind of slowly started getting autism symptoms back. So we're actually just starting him again after about 3 to 4 years back on IVIG, probably. This was a really interesting piece that the mother had of his handwriting. And so this is after 5 years of occupational therapy, right here. You can see how poor his handwriting is. And this is after 2 days of IVIG treatment. This is a unique case. This is the first case, I think, of the N-type calcium channel antibody that was found on the Mayo panel. This kid was an interesting kid because he was a little atypical. He had late regression type autism. He regressed after about 3 years of age. So he was very interesting, and he had this calcium type antibody. And with IVIG, you can see that the calcium channel antibody went down, but it took a while. Again, you can see the scale here. This is over a 2-year period. So sometimes this takes some time. And this is another interesting case, which I like to highlight, where we use the CAM kinase, which I was talking about, which could be so important. This was a girl who was successful on IVIG, and after a while we say, well, when are we going to wean this off? Maybe we should wean it off to see if they need it anymore. And many times what we'll do is we'll get a baseline CAM kinase to see where they are. And the borderline value is about 130. That's considered the upper limit of normal for the CAM kinase. And so her CAM kinase was abnormal at baseline. We brought it down towards the normal end here. And then we went from every 4 weeks IVIG to every 6 weeks IVIG. And you can see what happened is her behavior spiked. And our question was, well, is this something maybe, that happens at home, or some type of environmental thing that we don't know about? Or is it due to the fact that she was weaned off IVIG? So we did another Cunningham panel, and what you could see is that the CAM kinase actually went up. So suggesting that the autoimmune process was getting worse. And so then she went back on every 4 weeks IVIG and so I'll briefly talk about one of the papers. This has more to do with PANS PANDAS, of using the Cunningham panel we did with Craig and the group at Moleculara. And at this, we looked at kiddos that had a Cunningham panel and could be clearly divided into those that made improvements or did not make improvements. And then the Cunningham panel was repeated afterwards. And this is just a list of symptoms. Most of what you would think, these are PANS PANDAS patients. OCD, emotional ability, is at the top of the list there. And so this is a really nice graphic. And what's highlighted in red here is the abnormal tests on the Cunningham panel. And this is pre-treatment, and these are responders. And this is post-treatment. And so you can see very easily there's more red here and less red here. So it seems like the Cunningham panel actually predicted which kids got better. And then here we see these are the ones that did not respond to immunotherapy, that actually you can see that there's actually more red after treatment. So it's a nice test to actually ask, if your kid isn't getting better, what's going on as far as the treatment, if it's the treatment or something else. We found that by using that, it was predictive with a 90% accuracy as far as who was going to get better. And as if you look at therapies, most kids had antimicrobials and other immunomodulatory therapies. We looked at the accuracy of the Cunningham panel, and we found the reproducibility of the titers, that they were most of the time they were completely reproducible, but it was always within one titer, upper or lower, if you're considering the accuracy of it. And that if you're looking at the CAM kinase, that if you do the CAM kinase twice, that there's that it correlates 0.9, which is a great correlation showing reliability. And then I'll just, for those of you that may be familiar with the Cunningham panel or not, it had criticism by one study by the Swedes, and they found that they could not use it to really, for kids that had PANDAS, that it wasn't really predictive. But we'll just to put that to rest, there were several problems with their study, including that they used the wrong tubes to actually collect the blood. They didn't ask about family history of psychiatric disease, didn't ask about infections, nor did they ask about psychiatric symptoms, only psychiatric diagnoses. And when we regrafted, so they had a lot of problems with their controls, and when we grafted their results of CAM kinase compared to the original controls that were very carefully predicted, we can see that it was very significantly different. So I'll thank you for your attention, and I know you guys all want to get some lunch, so.
We really have no, Okay, so it was extraordinary again, and we are all now messed up in our hands, probably heads. So questions?
There's a question online. Can you please say what is the percentage of success of the treatment with IVIG of autism patients, and how long does the treatment last in your clinic?
Yeah, so in my talk, it's been taken down, but what we found is that there was about 90% had at least improvements in one or more symptom, and I think that it was about 70% had improvements in two or more symptoms, if you measure it like that. These, I must say, were, of course, selected patients. These are patients that had an extensive workup for other conditions, including metabolic conditions, seizures, and genetic disorders, and were found to be negative. So it is a subset of kids. So probably if you were to start out with, using this treatment, you'd probably have a much lower success. And that's one of the reasons why we try and use biomarkers and be very thoughtful about how we use these treatments, because if you use them kind of indiscriminately, then you're going to have a lower proportion of success, and it's going to be harder to treat patients. So in our hands, I would say if two or more symptoms, improvement is about 70%. And we find that many times you'll have to go for a number of months, a number of treatments. I think Dr. Chan has talked about going about 6 months, and that's what we usually do. Is we usually go about 6 months. We usually see some type of improvement within 3 months.
Thank you. And do you see patients anywhere besides Phoenix Children's Hospital in Arizona?
Yeah, I don't see patients besides that location, but I do telemedicine. So I do a lot of telemedicine. I have several, each week I do several international patients by telemedicine.
So patients from here can see Dr. Frye via telemedicine. Okay, anybody else?